now for our speaker, Nora Belcher. Ms. Belcher is the Executive Director of the Texas eHealth Alliance, which is a nonprofit advocacy group that she started in 2009 in order to give health information technology stakeholders a voice in public policy. The Texas eHealth Alliance serves as the state's leading advocate from local communities to the national level for the use of information technology to improve the healthcare system for patients. Prior to starting the Alliance, Ms. Belcher worked in the private sector as a consultant advising health information technology companies on how to do business with government. She also served in Governor Perry's office for 5 years as Deputy Director in the Governor's Office of Budget, Planning, and Policy, where she was responsible for managing the policy and budget issues for the Texas Health and Human Service System. Ms. Belcher holds a bachelor's degree, I said it before, I'll say it again, in government from the University of Texas at Austin, Hookham, which is the best university in the nation. Now let's welcome Ms. Nora Belcher.
Good morning, everybody. How are y'all doing? Wow. I've driven a lot farther to speak to a lot fewer people. This is fantastic. I'm so happy to be here because I'm so passionate about immunization policy and the importance of immunizations. And I want to make sure, because I did this in the last group, and get it out of the way. Yes, I worked on Governor Perry's HPV executive order. Yes, we botched the politics of it, but gosh darn it, we were right on the policy. And we will be proven right in the long run. So I have developed this crazy reputation to being one of the 5 Republicans that care about healthcare in the country, apparently. And I used to do stand-up comedy. So for the next 45 minutes, I'm going to make you laugh. I might make you cry. I'm going to give you a reality check or two, and I'm going to give you some causes for optimism, because I am an inherently optimistic person. If I wasn't, I couldn't work in healthcare and last for very long. And I think that probably goes for everybody in this room. Let's cover conflict of interest. I don't have any conflicts of interest to disclose, except stupid people. Don't like them. Other than that, I think I'm good. I run a nonprofit. We're a trade association. I represent health information technology vendors. I've been working with the Immunization Partnership. I worked on the Donna Howard bill last cycle. I am considered one of the state's experts in privacy and consent, and we'll talk about why that matters for your cause. Our wonderful moderator already covered the objectives. I love it when my slides get covered, so we can just plunge right in. Now, I know that Jason Sabo's already talked about the election results, so I don't want to dwell on the numbers a little bit too long, but I want to point a couple things out, and I want to talk a little bit about the incoming legislature. Obviously, we have, for the first time in many years, my old boss no longer in charge. It's very strange for all of us, especially because we are apparently not conservatives anymore. The running joke among former Perry staffers is we're now what's called rhinos, Republicans in name only. We're not conservatives. It's kind of hilarious to me. But we do still have statewide Republican leadership. The numbers in our House and Senate really didn't shift that much from a party perspective. 1 new Republican senator, 3 new Republican House members. That's not a big shift. What's important for you to know, though, is that half of both of those chambers are freshmen and sophomores. And that means some very important things. Number one, it means the staff are in charge, because that's frequently what happens when you have new legislators, and that's generally good. But more importantly, those people are not overly invested in the fights of the past. I was at the Public Health Committee the night the autism families showed up on the M-TRAC bill. Was anybody else here that night? Oh, be grateful. It was a madhouse, because I was on a bill that was after the M-TRAC bill. And this all got started, for those of you that don't know, by a rumor that the state was going to keep unvaccinated children out of shelters during emergencies. That vaccination status was going to become how we decided who got to be in and out of the shelters. So if you've never read that backstory, if you'll go to Google, the people who spread that rumor still have stuff on the internet, but have hard liquor with you, because you won't be happy by the time you read it. However, let's be fair. This was at the time when people thought there was a published study that linked the MMR vaccine to autism, which I'm embarrassed to say that former doctor, sorry, he lost his license. Former doctor, lives in Austin, and I don't normally advocate for homicide, but I might hit him with my car if he walked in front of me, because people are dead because of him. And in this audience, I think y'all understand, and I don't have to sell you on the damage that got done there. So, while we have this, what looks like Republican sweep, Republican wave, all of that is true, the note of optimism I want to sound is that we have a bunch of new people who aren't invested in those fights. And a lot of them didn't even really become active in public policy and politics until well after that stuff got debunked. So that's good. That's a moment, I think, for optimism and for being positive about our ability to get some changes done that we need. And by the time I'm done, I'm going to give you some more reasons to be optimistic. But this is one that really does tie to, I think, the feeling folks have this week after the election of oh boy, here we go again, or seriously, or oh my gosh, this is terrible. I understand that reaction, I really do. And I know for public health advocates, frequently public health is the redheaded stepchild, not invited to the table, sort of gets the leftovers. In this political climate, I'm not sure that's true, partially because of our friend Ebola, which, no matter how you feel about the rest of it, has caused flu vaccinations to spike. Yay, I will take that. Because I tell people all the time, 50,000 people a year die from the flu, and they think I'm a nut. I am not a nut. I'm a public health advocate. Stop it. Pay attention. It's not hard. But it is. You got to cut through all the chaos sort of with an effective message. I want to talk a little bit about the national wave, because there's some interesting policy things in what just happened nationally. Obviously, huge Republican wave, but this one was a little bit different for a couple of reasons. Not only was there a Republican wave at the congressional level, Republicans won governorships in states like Maryland and Illinois. We have more legislatures controlled by Republicans than in decades and generations. Well, what does that mean? Well, part of me thinks that some of it is driven by the fact that Americans tend to be deeply libertarian. And there's a kind of a reaction to government sometimes that happens that sends this mixed message that maybe we want a strong figurehead president, but we want our legislature to keep our taxes low. And we don't think that's schizophrenic. We seem to be perfectly comfortable with that. Go figure. All of that being said, this was a stronger performance by Republicans than anybody expected. Some of that was turnout, Democratic turnout, very depressed, technically and literally and figuratively. But the other piece of it is the Republicans learned some lessons from some of the really crappy candidates that they ran in previous years. For example, we didn't have somebody like Christine O'Donnell who actually made a commercial where she said, "I am not a witch." There's no reason for that ever in the history of anything. The other thing that is fascinating to me is that there were some public policy trial balloons being tested in some of these races that have some really interesting public policy implications. Let's talk for a second about the senatorial race in Colorado. The incumbent senator was Mark Udall, who decided that the war on women was going to be his theme, and he was really going to beat on his Republican opponent for being anti-woman, anti-birth control, anti-this, anti-that. It got so strident, it crowded out the rest of his message to the point where the press dubbed him Senator Uterus. Now, no matter how you feel about lady parts, that is not a compliment when that becomes your nickname in the press. Part of the reason his opponent won is he did a very interesting sort of policy political jiu-jitsu. He came out as an advocate for over-the-counter birth control, which the American Medical Association, by the way, has backed. Now, you can have a reasonable policy discussion about whether or not that's good. But as a trial balloon, it seemed to deflate Senator Uterus a little bit in terms of attacking his opponent as being staunchly anti-female. So what does this tell us? This tells us that people are learning from things that went wrong in previous cases. Another lesson that I think got learned in a harsh way was, God bless her, Allison London Grimes, who was running against Mitch McConnell. Should have said she voted for the president. Should have said it. Refused to say it. Why would you do that when you're a Democrat running against a Republican in a state like that? Why would you do that? So I expect in the next cycle, the Democrats will learn from the things their candidates did wrong. Everybody adjusts. It's this big shift back and forth. It's really fascinating, but a lot's at stake. So it's also really important to pay attention. So you see people learning lessons from what worked and didn't work in 2010 and 2012. That puts them sometimes in a position where they then have to to make decisions based on the changes they made in their strategy. So some interesting things to sort of watch there. I should also say that Colorado also did legalize marijuana, not just medicinally, but recreationally. So I'm not sure you can use Colorado as a microcosm, that everything that's done in Colorado will work everywhere. But it's still interesting to watch the changes in the policy shifts. Last thing I want to say about the Texas legislature is, yes, they're conservative. Shocking. They're very conservative. There's a phenomenon going on. How many people in this room have ever heard of something called the Great Sort? Any of you heard that term before? A guy that used to write for the Austin American-Statesman, Bill Bishop's written this book about how between technology, where jobs are, a whole bunch of factors, we have sorted ourselves into communities that match our values. So there are some maps making their way around the media right now that show the coasts is blue, and then you have some blue dots. Austin is a blue dot. Boulder, Colorado is a blue dot, occasional blue dots, but the rest of the country is red. 50% of our people live in the blue stretches, 50% of our people live in the big red swath, and they call that the Great Sort. That's really interesting, because I think that's part of what's driving the national vote being one thing and the local vote being something different, because people are sorting themselves sort of into places that match up with them, and that impacts things like the Electoral College. So if you're not familiar with the Great Sort and you find demographic stuff to be interesting, I highly recommend you look the book up. Fascinating conversation. All of that being said, Texas Democrats are still more conservative than Massachusetts Republicans. Our state still generally tends to be very conservative. We send conservatives to the legislature. However, we have brand new leadership for the first time ever. It feels like forever, because it's been 14 years, let's face it. That's an opportunity to have new public policy discussions, and there's some really good reasons to be doing that I'm going to talk about here in a minute. I'm going to change gears, though, and talk about my favorite slide in the history of PowerPoint slides. You'll notice, by the way, I don't read slides. I also think those people should be banned forever from giving speeches in public, because that's just offensive to me, especially if they read slower than I talk. I love this slide because it shows the breaking of the dam of the internet. When the internet went from just being kind of what the nerds like me did to something that everybody was doing. Do you remember the morning that you woke up and everyone else was on Twitter? And you were like, what? What? I would have passed on Twitter as an investment. 140 characters and hashtags, who's going to do that? So that'll show you how much I know. The internet changed when content became useful and accessible. I want you to remember those two phrases. My 18-year-old does not believe that there was a day when you couldn't open a Mac document on a PC. Right? He thinks I'm making that up. He has no concept of a world where information was not freely available and interoperable. In healthcare, we're behind. Is our content accessible? Is our data on our patients accessible? Is it easy to get to? Is it easy to understand? Is it standardized? Any of those things? Hell no, it's not. But it's going to be, and that's what we're in the middle of. And so this wave is heading our direction. We're not there yet, but it's coming. And in that wave, for the immunization community, is tremendous opportunity. Huge. Huge, 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 as Julia Roberts said in Pretty Woman. Huge. I want to follow this with a couple data points about technology use in low-income populations. Because frequently when I give that first slide and I talk about technology and social media and all those things, I get a lot of, well, but I work with lower income populations. I work with Medicaid. I work with the uninsured. They don't use those tools. Yeah, they do. Yes, they do. As cell phones have become ubiquitous, they've become cheap. We're looking at, and this was 2012, by the way, so these numbers are higher now. 77% of individuals with income below $25,000 to $30,000 a year had a cell phone. Do you know what you can do with a cell phone? It doesn't even have to be a smartphone to send text messages to remind people to take their medications, or to remind them that they have a doctor's appointment, or to communicate with them. So there is a whole revolution happening here. I also think it's interesting that Texans own and use technology more than the national average. Now, my mother's family is European, and they think I go to school on a horse. They do. Which I might, but I'm going to have my smartphone while I'm going to be tweeting from my horse. We are a technology-savvy state. So These are important things to keep in mind because I'm going to talk about the evolution of technology in healthcare and policy, and I want you to be mindful that this is not just for the upper class. This technology has become ubiquitous. It's really for everybody. I want to talk really, really quickly about some of the state-level activities. There's been literally $1 billion investment being made in electronic medical record systems for hospitals and healthcare providers. Federal mandate, I would have written it differently, but it needed to be done. And yes, it sucks, and I understand the products are terrible, but they will get better with time. This is a big change, and it's a big ecosystem, so changes slowly. We're also standing up a health information exchange infrastructure. So for those of you that might not be familiar with that topic, it's the idea that you are in San Antonio today, but maybe you live in Houston, you're in a car accident, the ER here in San Antonio could pull your record from Houston, find out what you're allergic to, find out if that thing they see on the brain scan is a new thing or an old thing, opening up data sharing. That's the classic use case, and I kind of don't like that use case because that's an exception. That's not the rule. 80% of healthcare tends to be local. Where health information exchange as a verb is really powerful is if Sally likes to go to one ER on Monday and the other ER on Wednesday and take her prescription to CVS on Monday and to Walgreens on Wednesday. That's going to be the power of the digital infrastructure. That's going to be, as Garfield would say, a big fat hairy deal. Because when we do that, then we start to cut into the duplication and the repetition and the lack of information and the lack of context. The other trend is the idea that we can use technology to expand service delivery. Everyone in this room knows we don't have enough psychiatrists, we don't have enough pediatricians, we have no child specialists of any kind or sort that you can get an appointment within 6 months. So there's all sorts of things we're starting to do with technology now to extend service delivery, and this has changed very, very quickly. A week ago, actually probably right this minute a week ago, I was at the medical board listening to a conversation about using FaceTime under bridges with homeless people so psychiatrists could see something happening and help the EMT and the mental health officer with the assessment in the field. Crazy, right? But what if you started doing home visits via FaceTime and you could see whether the person had become a hoarder in the background, or you could get a better feel for what their home looked like? Now, you've got to deal with privacy and consent and sort of all that sort of stuff, don't get me wrong, but we used to be having a fight about whether it was possible to do it with technology. We're not fighting over whether or not it's possible. We might be fighting over whether or not it's appropriate, what's appropriate, laying hands on versus virtual care, but it's no longer about what's possible. And that is terrifying and absolutely exhilarating all at the same time, especially for someone like me who's a technology advocate. We have to be smart about it. We can't cut out the human touch. The best solutions are actually going to be a combination of high tech and high touch. We use technology to do the routine stuff, and we save our precious resources for the situations where they're really needed. So as you look at technology solutions and innovations, that's a framework I'd encourage you to keep in mind. Think about, are we losing our touch when we go high tech? Or how can we continue to be high tech and high touch? Because that's the combination, I think, that can really be the difference maker. I also want to mention a process called Sunset, because you're going to hear a lot about this over the next 12 to 18 months. Sunset is a process in Texas where we have an independent agency that looks at areas of state government and says, are you doing your job? Are you doing your job properly? Have you had scope creep? Are you still producing that report from 1978 that nobody reads that goes on a shelf? Because we do that in government. I see some nods. Some of you probably get that report. You know, and we still send it out in the mail to 3,000 people, 100 or 200 of whom are dead. I mean, we just don't stay caught up like we should. So what Sunset does is looks at agencies and says, what are you doing? Are you doing it right? Could you do it better? Could we reorganize in a different way? Now, what's fascinating about this cycle is that we are looking at the Health and Human Services Commission, which is a third of state government, all at the same time. Medicaid, public health, long-term care, rehab, child welfare, all on the table. And the recommendation is to consolidate it all into one super agency with programs under it, because our previous attempts at consolidation still produced a lot of silos. Public health is shockingly siloed, right? And that's not good for our patients and the work we try to do. The analogy that I used to use for years about state health services, which is people I love work there, so I mean this with love. It's like dealing with a bunch of lost Amazonian tribes that don't even speak the same language, and they're just standing in front of their program with their shield and their spear. Oh, my data, mine. Well, no, actually, it's our data. It's not just your data. So there's a mentality shift that still hasn't completely happened there, and we got to do some work. We also have an aging infrastructure. We have software programs from 1978 that are still running over there. Up till a couple of years ago, we were still hiring COBOL programmers. Some of the people in this room I know are too young to even know what COBOL is. Remember War Games? That was written in COBOL. That's how old that programming language is. We still use it in government. So we got to get with it. We got to modernize. We've got to improve. And we can't just rearrange the deck chairs on the Titanic. We've got to bring better, stronger governance, better, stronger decision-making to the table. So let's talk specifically about the upcoming legislative session and topics that relate to immunizations. Public health registries. Now, this is bigger than just MTRAC, but I actually get to MTRAC bash here for a minute. And again, I do these things with love. But remember the scenario I was talking about a minute ago where she's in San Antonio and she's in a car wreck and her record gets pulled over from Houston. As we stand up these health information exchanges, this data infrastructure, we are actually wanting to include public health data in the databases and in the exchange of information. So if I'm a doctor or I'm a hospital and I'm already participating in this data sharing, we had this idea, well, what if the HIE could do the data reporting for public health? Because I'm already sending them my data, so I have to do it twice. Why can't I just do it once? Okay, now this is the point in the room where I have to ask if there are any lawyers in the room. Any lawyers? Okay, good. There's two kinds of lawyers. Lawyers who see what's possible and lawyers who say no. So as we started to work on this idea, we ran into a lawyer who says no. And that lawyer said, well, the statute says that providers are required to do the reporting. It doesn't say health information exchanges. And we said, well, why does that matter? They're doing it through a contract. They have a business agreement. They're reporting on behalf of the doctor. And they said, nope, providers got to do it themselves. They can't get any help. Really? Okay, so we're going to have to amend the MTRAC statute to permit these exchanges to report on behalf of their providers, which I think is ridiculous. However, I am not a lawyer. I write law for a living, and then they mess it up. Very annoying. We have to make this fix, though. And here's the exciting part. And I didn't actually get to talk about this last session, and I'm sorry that I didn't. We are working with DSHS to create what we call a public health reporting gateway. It's going to be a drop-off place for public health data using electronic medical records. You're going to be able to hook a doctor or a hospital's EMR directly to the department and drop off all your data. Your labs, your immunizations, eventually syndromic surveillance, anything that needs to go, and then Dishes is going to take it and send it to whatever department needs it. Otherwise, you're going to have 26 web portals, 26 logons, 26 passwords, and 26 pipes of data. And right now, it can cost up to $15,000 to build a bridge between an EMR and MTRAC. And that is absurd. So the good news is this agency is being shockingly progressive on this particular front. We still have to address the legal issues, but they're building a technology infrastructure that's going to simplify all that data reporting, clean it up, make it cleaner, make it faster, make it more efficient. And I have a dream. I'll tell you about my dream for a second. My dream is public health data that's not 4 years old. That's my dream. And without health IT and EMRs, you're never going to get there. So we all have to work in partnership to get that piece of it done. Huge, exciting potential. Speaking of huge, exciting potential, I'm not satisfied with just getting Dishes to change how they do business. We are actually working to get the entire health and human services system to be more friendly to the use of electronic medical records. Right now, state agencies have this tendency, if you tell them to put something online, they go, oh yeah, that's great, we'll make a PDF, and then you can print it out and sign it and keep 3 copies and 1 in the file and you send it in to us, right? No. I've had it, I'm done, no more of that. Also, can I say I'm coming for their fax machines? I am actually planning to propose a budget rider to ban the purchase of new fax machines at the Health and Human Services system because I've had it. Faxes are not safe, they're not secure, And if you're faxing in information that's then transcribed into a data system, you have data degradation, you have data loss, you have incorrect data. It's what we call swivel chair. I'm going to sit here in my swivel chair and type the thing. No other industry would settle for this, would they? Now, to be fair, our ecosystem is much more complex than other people's industries. The analogy that I hate the most is banking. Oh, electronic medical records, they're just like ATMs in banking. An ATM, thank you for laughing, an ATM transaction has 6 data fields. We can't even do patient demographics with 6 data fields. You can't even correctly pin down a Mary Garcia in Houston in 6 data fields. The most complex online financial transaction, I've been told, has 42 elements. Can you even do Texas Health Steps with 42 elements? I'm not sure you can. I see some heads being shaken. So while this is so much more complex, so much harder, it is so much more meaningful, and it will get so much more better as we standardize, as we make these things digital, as we pull these systems together. The fragmentation in the system, and this directly relates to those of you that have worked on the MTRAC consent issue, people have historically perceived the fragmentation as a feature, not a bug. They believe fragmentation protects people's privacy. It doesn't, really, and what it does do is it constrains the healthcare system from actually treating the patients the way they should be treated. So we got to get past that. We've got to get past this illusion that fragmentation protects privacy. And part of how we do that is by forcing the agencies to use standard systems to collect data so we can leverage our electronic medical records and everybody's speaking the same language. A couple more of these for you. This is an initiative that I helped create that I'm very excited about, which is a health information exchange for our Medicaid CHIP program. Right now, if you're a provider and you're treating a new Medicaid client you've never seen before, do you know anything about that client other than what they tell you? Can you see their prescription history, their visit history, their hospitalization history? Wouldn't you like to? We're testing that right now. We have a pilot going to expose Medicaid claims history to providers. The idea started with foster children. For those of you that might have some intersection with foster care, we built a foster care passport. That was a project of mine. I'm very proud of that project. It's done a lot of good for a lot of kids. And then we were like, why don't we do this for all of Medicaid? Because we know these are folks who move around. They change providers a lot. They move from town to town. They might even be seasonal in their work. And so every time they get a new doctor, what do? They start over. And that is just, should not be acceptable. Now, there's privacy issues that we've had to hash through around that. We have to get them to consent to share their data. We've had to deal with how do we deal with sexual abuse data, with HIV data, with 42 CFR Part 2 on substance abuse, which is the trickiest one of them all. But we've hashed through a lot of that. So I'm hopeful in the next 12 to 18 months we'll be rolling this out in a way that those of you that work with the Medicaid population will have a chance to actually access data on your patients before they show up, or when they show up. Or even if you're in a real hurry, at least compare the old history to the new history you just took in the office. And hopefully that starts to show some benefit because people will be better informed about the folks they're taking care of. I want to switch gears quickly to the consumer technology side, because here's the deal, folks. Here's the bottom line. The only thing you can't do on a smartphone is see your doctor or a doctor. And guess what people want? They want to see doctors on their cell phones or from their laptops. Nobody has time to take 3 or 4 hours off to sit in a doctor's office for an appointment. And the consumer revolt, I want to go back to that slide of the explosion of accessibility, is coming for the service delivery side. Now, this does not mean that physicians aren't still the center of treatment. But the truth of the matter is we don't have enough doctors, and there's all sorts of ways we can use technology to affect and extend healthcare. And there's 2 fights here I want to talk about really quickly. Fight 1 is sort of the virtual doctor's office, virtual doctor's visit. Now, I have another dream. I have lots of dreams. I sit around and make up this stuff. I was talking to a lady the other day who has 5 children. They all got strep, but not at the same time, which meant she had to get off work 5 times to go in for 5 strep tests for her 5 children. So here's my challenge. Anyone in the room entrepreneurial? We need a strep test that you breathe on, that she could show on the video, look, and the doctor could say, her pediatrician, by the way, not a strange doctor, could say, yep, there's number 5, I'm sending the prescription to your office. We have to start thinking differently about how we do some of these things. We need to use technology to extend our providers, help them be more efficient. And the other thing that's exciting is the idea of not just leveraging telemedicine, but things like wearables. How many of you have a Fitbit thing on your wrist? God, I hate you people. I'm so lazy. Everybody I see with a Fitbit, I'm like, you exercise, don't you? Ugh, I do not. But the Fitbit is just scratching the surface. I want to tell you about my absolute favorite thing in the whole world right now. How many of y'all have ever been to a NICU? Okay? To me, the most heartbreaking thing about a NICU is looking at that baby and all those wires. It just guts me. That baby's already having a bad day. We're sticking all this stuff in that poor baby. At Brigham Young University, they have invented a onesie that has all the sensors built into the onesie. Okay, who's got goosebumps? All right? This is the future of health information technology on the consumer front. Things like infant wearables. The next evolution of I've fallen and I can't get up will be extraordinary for our elderly folks that want to be at home and not in a nursing home. And part of this means aggregation of data. And how that's important to the fight for good immunization policy is that we're moving to the era of consumer demand. Consumers are going to want curation, so accuracy, and aggregation of their own data. They're going to want to know what the government has. They're going to want to know what their doctor's going to have. They want it in an accessible format. How many of you have a patient portal through one of your doctors right now? Isn't that great? I got my mammogram results 5 days earlier than getting a letter in the mail because it went to my portal. The problem is I turned 40, my warranty expired, I have 8 specialists, 8 portals, 8 passwords. No, exactly. Is that acceptable? No. Are consumers going to put up for that very long? No. Is immunization data being left out of all that aggregation going to be acceptable? No. There's an opportunity there to talk about the fact that fragmentation is not a feature anymore, it's a bug. Fragmentation is a problem, you've got to take a 360 look. Folks are going to want access to their records. They're going to want online access to their doctor, or a doctor in a pinch. And then they're going to want to use wearables, collect that data, have that data be integrated with the rest of their health care. On the downside, we still have some significant challenges. Challenge number 1, and if you work at a hospital or a doctor's office, you're probably already feeling this. People are already starting to question whether this investment in technology is the right thing to do. Because we've spent billions of dollars. Where's the return on the investment? Now, show it to me. This is hard. This requires time and patience, but we'll get there. In Texas, we don't have giant state aggregations of data in a lot of places except for public health, so we have a lot of fragmentation in the system. Fragmentation with local providers, fragmentation with hospitals. We've got to work on that. The goal is going to be to get to a 360 view of the patient, and I'll tell you how serious that is. I'm going to give part of the answer I gave Anna in the last session. 42 CFR Part 2, which is what protects substance abuse data, means if you want to access somebody's substance abuse treatment records, you have to get specific consent from the patient for the specific reason for the access, and it's time limited. So it's super, super secret sensitive data. However, as we've been bringing accountable care organizations online, the ACOs are financially at risk for the patients assigned to them. But there's this firewall. They don't have any idea if the patients that they're responsible for have substance abuse history or are getting substance abuse treatment. So there's starting to be a national conversation about whether that data should be exposed. Still maybe with consent, but maybe not as restrictive a consent policy as we currently have. So this direction of getting rid of the fragmentation and moving to a 360 view, if you told me 42 CFR would even be on the table, never in a million years. And there's still a lot of resistance. I think folks are very split. There are still folks that think that will keep people from seeking treatment, and then there's a lot of folks that think that liberating the data, treating the whole patient is the way to go. The final thing I'll say is kind of wrapping back to my whole what to expect from the Republican legislature. We're going to have a surplus this cycle. That's horrible. It's terrible, because how can they go back to their constituents and brag about all that wasteful state spending they cut when there's a budget surplus? It's an actual conundrum. Like, it's freaking people out. It's kind of hilarious. So what do Republicans do when they can't cut the budget? They deregulate. And in deregulation is opportunity for revisiting things like MTRAC, where we have sort of regulations that don't make a lot of sense. There's a conversation happening right now about whether the state should regulate contact lens dispensers. Yeah, we do that. Your tax money pays for that, even though there's a national registry. We have a state registry for x-ray technicians, and we've only disciplined 13 of the 13,000 of them ever, like in the history of our registry. So that's a list, okay? That's not a registry, and that certainly isn't a regulatory program. Real serious conversations about deregulation, again, create some opportunities to look at some of these barriers to data sharing, to holistic medicine, to treating the whole patient. And believe it or not, I think that that's a place where Texas has a unique opportunity because we're perceived as being stronger on privacy. Privacy is sort of this issue where the far left and the far right really agree. They're afraid of different things. Some might be afraid of big government, some might be afraid of their employer, so we hoard data, we hoard our private information. But when it comes to treating people to the business that we're in, that hoarding is bad because that hoarding means duplicate tests, bad information, duplicate services, and in some cases, I want to end with this anecdote because it just really got to me. The HIE in Houston was telling me about an elderly woman that showed up in an ER in Houston, and she was being asked the standard questions, including, "Are you allergic to any drugs?" She said, "Yes, I'm allergic to penicillin." They said, "Great," they wrote that down. She had an infection, they treated her with a sulfa drug, turned out she was allergic to sulfa, and she died. Now that piece of information was in a computer somewhere because she was older and she couldn't remember. Is that acceptable? And so it's not any more acceptable to hoard immunization data either. And I think there are real opportunities to advance that policy. I'm going to be working with Jason, with Anna, with the partnership. I'm going to take another whack at it this session. And when you look at the direction that digital medicine is taking us, it is completely absurd to say you can have everything but this. It's not going to be acceptable anymore. So I'm excited about the future. I'm actually excited about the potential for the integration of public health and immunization data into the broader digital universe. I'm excited for those NICU babies. And with that, I think I'll stop, see if there's any questions. Thank you very much.
So at this time, we will open it up for questions for Nora. Is there anyone that has a question for her?